Yeah, thank you very much. It's great to be back with another cohort of from Pallium India. Let me just see. I'm just going to try to view everyone in gallery. Yeah. So I before actually getting started, I was just wondering if there are any folks here who have had prior experience or just encounters with the LGBTQIA community in the context of healthcare. It could be palliative care, it could be some other form of healthcare. If you are somebody who would like to share, just go ahead, unmute and introduce yourself and please go on. This is just for me to get a sense of where the group is with respect to prior exposure. Anyone? So once again, my question is to ask if there's anyone in the group who has prior exposure to the LGBTQIA community, especially in the context of healthcare. If it's not in a healthcare context, but another context like somebody or something, that's also fine. Yeah, so just like to hear a little bit from the participants before I get started. Anyone? I see 18 people on here.
Hello, doctor. Good evening.
Yeah,
this is Aparna. I don't have exposure in terms of healthcare, but I do have had several interactions with folks of the LGBTQIA plus community. And I especially work with transgenders through an organization called Periphery in Chennai. And they work primarily to help in empowering and educating and preparing transgenders to get into the workforce in terms of improving employability, communication skills, technical skills, basic digital awareness, graphic design, Canva, and all of that.
Yeah.
So my job there, I've been harnessed as a coach. So I coach them primarily in terms of body image and self-issue, whatever issues they have in terms of connecting, relationships, and all of that. So that's as far as my interactions go. Plus, I have friends who are from the LGBTQI plus community and who have especially moved out of India because our country wasn't that time in a favorable position in terms of outlook. So they stepped out and they became citizens of the US and other countries where it was more favorable for them to get married and settle down. So I know of folks within my friend circle.
Right. Thanks, Aparna. Yes, Neelam of Periphery, someone I've worked with before, and we've done some collaborative work as well. So excellent to know. Thank you, Aparna. Anyone else? You can just unmute and go ahead. Don't bother raising your hand and being called out. Just go ahead.
Sir, I believe you saw the chat as well from Aparna. She did her master dissertation, resilience and psychological well-being in transgender community. So she might have had. And Nita also says she had an experience working with them, concerns like well-being and psychological concerns.
Okay. I'm trying to see where the chat window is. Yeah. Okay. Great. Thanks. So what I'm going to do is, 1 second, working in concerns. Oh, yeah. Okay, great. So I'm going to try to share a screen. So this is going to be an overview of what palliative care providers, whether you're medical or mental health or other, palliative care providers, what you should know about gender, sexuality, and mental health, particularly in the context of LGBTQIA people needing palliative care. But without wanting to assume that everyone has had the degree of exposure that Aparna and a few others may have had, I'd like to go through a few basics and then delve into the issues of mental health issues of the LGBTIQA community, as well as the concerns in terms of accessing healthcare and palliative care. I intend to close with an overview of 2 or 3 recommendations or best practices that have come globally, and then maybe get into a discussion on what we can do in our Indian context. Like was said earlier, there are people from the LGBTIQA community who have a lot of, they've had education and the resources and privilege to be able to move to a country that actually has laws and policies recognizing queer and trans relationships, might prove to do that. But if you look at the entire population of the country, as per the Supreme Court verdict of 2018, 8% of India's population is from the community. That's about 10.9 crores. And about 24% of them are estimated to be below poverty line. And there are a lot of social factors also contributing to keeping them below poverty line. And one of them, which we can get to later, is the issue of out-of-pocket expenses for healthcare, because there's very little affirming healthcare available in the public health system, even though that is changing. And a lot of people save for years, they do sex work, they try to earn a lot of money, as much money as possible for gender affirming care and other reasons. So, nutshell, the LGBTQI, is anyone saying something? I'm hearing some voice.
Yes, sir. Sorry to interrupt, but were you moving the slides? Because we are seeing only the intro slide even now. So
yes, I'm still on the intro slide.
Okay, thank you.
Yeah, I'm still on the intro slide. I'm just doing some context setting before actually launching into the slides. So yeah, the context here from the first slide, which is not actually written on here, is that there's about 10.9 crore LGBTQIA people in India. Some of them are visible. The trans women that you might be seeing from the Hijra or Kinnar community, begging, at traffic signals or on the train, or seeking alms or engaged in sex work. These are the visible subset of the community. A lot of the community members are actually invisible, which also contributes to the problem. So what I will talk about is a quick overview of concepts. I will talk about stressors from a mental health perspective and their impact, touch a little bit on family, society, but then zoom into health, and then talk about barriers and best practices in accessing palliative care. So when we talk about LGBTQIA, there are 3 distinct components. One is sexuality. The other aspect is gender identity and expression. And a third aspect is what we call sex characteristics. So when we talk about sexuality, again, there are 3 subcomponents in it, which are overlapping, which is sexual orientation, who one's attracted to, sexual behavior, whom one engages sexually with, and identity, what one identifies as. So imagine a situation of a woman who is only attracted to women living in India, middle class, maybe small town India. She knows for herself that her attraction is only to women. So from a purely scientific perspective, her orientation would be what you would call that of a homosexual female. However, depending on how open or closed her family is, what are the restrictions she faces, she may not have any opportunity to explore her orientation in terms of getting into relationships. Even worse, the family may force her into getting married and engaging in a relationship with a husband and who belongs to a gender that she's not attracted to. So here is straight away we see that orientation and behavior may or may not overlap, especially in a society where there are a lot of restrictions against expressing the behavior that feels natural to one and that's aligned with one's orientation. And such a woman, depending on how repressive her immediate surroundings are and her family is, may or may not have the luxury of identifying herself as a lesbian, which she might if she was staying away from parents in maybe an urban metropolitan center in India. So you have a lot of people whose behavior is homosexual, but who have not been exposed to the community, who may not have the vocabulary for it. There are people who may engage in behavior in certain contexts where they're actually not oriented towards that gender. So we often speak about male-to-male sex happening in prisons or happening in the army and in other situations where the context is one of, a lot of restrictions on going out, inability to have a family life. And there is what is called opportunistic homosexual behavior, even though these men may not be attracted to men. It may be just opportunistic sex that they engage with during the period that they are incarcerated. So there's a question where there's behavior without necessarily an orientation or an identity going together with it. Let's take an example from religion. So you may have a priest from a religion that says that if you're a priest, you can't get married, you have to lead a celibate life. Such a person may actually be homosexual or heterosexual or bisexual or whatever. So the orientation may be there, but the behavior may be one of celibacy, not engaging in sexual relationships for religious reasons. And the person may not identify as gay or bi or anything. The person may only identify as a priest. That would be their identity, right? So the three may overlap, and where they do not overlap, there's a discordance. So from a mental health perspective, if somebody has an orientation that's to a particular gender, like the same gender, and they are forced to behave, to engage sexually with someone of a different gender to whom they are not attracted to, this will have mental health impacts. So we are only talking about sexual orientation, behavior, and identity. Now I'll move on to gender and gender identity. So a lot of you who have had sort of social sciences or humanities backgrounds would have been taught that, sex is biological and gender is social, which is fine as a preliminary definition. But gender is actually more complicated. And we now use the word gender for the social aspect of and gender identity for the individual's innermost feelings. So we know biological sex, or at least we think we know biological sex. It's the sum totals of your internal, external body parts, hormones, chromosomes, etc., etc. And if a child is born with male body parts and the doctor pronounces to the parents, you have a boy child, the parents are happy because this is a patriarchal society. They will raise the child as a boy. And when you're raising a child as a boy, there are do's and don'ts that boy is expected to do. So a boy is supposed to be outgoing, extroverted, aggressive, sports oriented, outdoorsy, etc., etc. In contrast, a girl or a woman is supposed to be more domestic, supposed to be more homebound, more interested in preserving cultural values. These are all stereotypes, right? But the point here is whatever, and these stereotypes can also vary by country and culture. Wearing a lungi or a mundu or a kilt may be perfectly acceptable for men in certain societies like in Kerala or Scotland or Tamil Nadu, but wearing or a sarong in some Southeast Asian countries, but wearing something like that would be seen as feminine in other cultures. So there is also a cultural aspect to gender, and gender is the sum total of roles, behaviors, activities, even attire and attributes that a society considers appropriate for men and women. And if a person, especially a child, is walking or talking or dressing in a manner that is not considered appropriate for that child's social gender, which in turn is derived from the biological sex, you would refer to that child as gender non-conforming. Okay, and as many of you know that a gender non-conforming child, especially a male child who acts in a way that is feminine or effeminate, can be subjected to a lot of teasing and ridicule and violence and so on. A girl child who is behaving in a way that society seems more masculine, feels more masculine or tomboyish, is probably tolerated a little more up to the point. So beyond that, they can't continue to wear boys' clothes and have short hairs and climb up trees and so on. There's a point where there's, especially around adolescence, that girl is expected to tame, get more domesticated and behave more feminine, lest her chances of eventually finding a man are lost, right? So you have gender. You also have what the American Psychiatric Association defines as gender identity, which is a person's deeply felt inherent sense of being a boy or a girl or a man or a woman. And the person, let's say, is born with the biological parts associated with a male. and is raised as a boy, the child may actually feel that I'm not a boy, or that I am a girl, or that I'm neither a boy or a girl, or I'm both a boy and a girl. So all of these is in the person's feelings. Okay, it is not necessarily correlated with any variation in body parts or levels of hormones or anything like that. There's just the individual self-perception of gender as opposed to society's gendered attributes. So this is what is called gender identity. And the gender identity, if you're born with female body parts and you're raised as a girl, and you feel yourself as a girl or a woman and you have no issues with that, then you are referred to as cisgender. But if you don't feel that way, if you feel your gender identity is different from what society expects, which in turn is based on your body parts, then you're referred to as transgender. So cisgender and transgender are the two types of gender identity. There is also a gender identity called non-binary, which some people club with under the transgender umbrella, but some people don't, and it's often an individual's thing, individual's preference. So delving into this a little more deeply, I'm going to go through a few definitions, and please stop me if I'm running. Transgender is a gender identity which is contrary to or different from the gender assigned at birth based on biological sex. I say gender assigned at birth based on biological sex because when a baby is born, you only look at the genitals. You don't do a scan to see what's inside the body. You don't take a blood sample and do a karyotyping of the cells. Just based on external, morphology, the doctors will pronounce that this is a boy or a girl. Occasionally, a child is born with indeterminate body parts, or what are called atypical genitals, and those would be intersex, and we'll come to that in a second. But I want to point out that that is not transgender. Okay, transgender is basically referring to a person who has a gender identity which is different from the socially assigned gender, and the socially assigned gender in turn is based on the assigned sex at birth, which is the gender assigned at birth based on biological sex. So a person who is not transgender, which is presumably the majority in this class in this session, are cisgender. Within the transgender umbrella, you have people who consider themselves binary and people who consider themselves non-binary. So a child who is assigned female, who identifies themselves as a boy or a man. So they identify themselves as with a gender identity opposite to the social gender. And this would be a binary transgender person, specifically a trans man. Similarly, a person assigned assigned male at birth, whose gender identity is that of a woman or a girl, would be a trans girl or a trans woman, which is again a binary. You're going from one gender to the opposite in terms of your gender identity. If you don't identify as either man or woman, then that would be a non-binary gender identity. And there are many flavors of non-binary, like genderqueer, gender fluid, etc. Legally speaking, as per the Transgender Rights Act of 2019, non-binary persons also come within the transgender umbrella, and intersex persons also come within the transgender umbrella, which is scientifically inaccurate, but legally it's we just go by the word of the law. The other aspect that I want to cover before moving on is earlier in the previous slides, I talked about sexual orientation, how one may be attracted to the same gender, other gender, multiple genders, or no genders. So someone who's attracted to the same gender would be gay or lesbian, who's attracted to multiple genders would be bisexual or pansexual. The difference between bisexual and pansexual is a bisexual person is attracted to more than one gender, while a pansexual person describes their attraction as independent of gender. And an asexual person who is someone who does not feel attraction, or who has limited attraction, or only feels attraction, sexual attraction, after a long period of romantic attraction. So I'm not going to go into terms like asexual, gray sexual, demisexual, etc. But you just keep in mind that this is all about who one's attracted to, and that is sexual orientation. In this case, what I'm saying is gender identity is independent of sexual orientation. So a trans man, a person assigned female at birth who identifies as a man, you may expect that such a person will be attracted to women. And that may be the case in many, in probably about 80% of the situations. But there are also trans men who are attracted to other men, trans men who are bisexual or pansexual, trans men who are asexual, etc., etc. Similarly, a trans woman could also be asexual, a trans woman could be lesbian, a trans woman could be heterosexual, etc. Even though the most visible segments of the trans community are trans and heterosexual, meaning trans women attracted to men and trans men attracted to women. But this is not the full story. You also have people of different sexual orientations within the transgender umbrella. Now, traditionally in Indian languages, we have very few words for sexual orientation. There's one term called Samlangi in Hindi and associated languages. Then you have Tanpalir Palar, which is in Tamil for someone attracted to the same gender. But for trans people, there are quite a few words in Indian languages. Nupi Manbi is a term from Manipuri for trans women. Hijra and Kinnar are from Hindi and Urdu. Tirunangai for trans woman and Tirunambi for trans man are from Tamil. Aravani is an older name for trans women. And then there are also English words like gender fluid, agender, non-binary, etc. So far, when I've talked about the LGBTQIA spectrum and been laying the foundation for what will follow, I've talked about sexual orientation, I've talked about gender, the social gender, as well as the innate gender, which I'm referring to as gender identity. And I've said that people can be cisgender or transgender, and within transgender, they can be binary or non-binary. Now I'm talking about gender expression. So regardless of how an individual identifies or doesn't identify, society looks at people and puts them in boxes. So the example I gave earlier of a biologically male child who is going to school but acting in a feminine way, or a way that society perceives or classmates or teachers perceive as feminine or effeminate, right? That we can refer to as gender non-conformity or non-conforming gender expression. And this is the greatest source of vulnerability, or it is an important source of vulnerability. If you look at children being bullied in school and children dropping out of school, there are some reasons, of course, pertaining to real or perceived caste, real or perceived socioeconomic class, whether they speak English properly, whether they're wearing nice clothes, whatever. But a child who is gender non-conforming or has non-conforming gender expression can be subjected to everything from teasing to bullying to sexual violence, not just from fellow students, but also from teachers and staff. So a child may not know whether the child is trans or cis, or whether the child may be before puberty and the child may not even have an idea of who they are attracted to. But the gender expression and the non-conformity of the gender expression renders children who are gender non-conforming vulnerable to bullying and abuse, and such children are more likely to drop out of school than children who have a conforming gender expression. So when we do the Sati, the NGO I work with, do sessions for educators at primary school or educational administrators, we tell them, don't worry whether the child is LGBTQIA, just worry if the child is vulnerable to bullying, and keep in mind that gender non-conforming expression can be one of the risk factors for bullying and abuse. Yeah. So actually, this is gender non-conformity is basically referring to gender expression that does not conform to society's expectations. Now, one point here that I haven't said before, a gender non-conforming child may, as an adult, identify as heterosexual, gay, lesbian, bisexual, or as transgender. In fact, there is a study in North America that followed male children who were feminine for a period of 20 years. It was a longitudinal study. And they found that about 20 to 25% of such children only identified as transgender while growing up. The others identified as straight or gay or lesbian or bisexual. And in some cases, the gender non-conformity faded away with age. In some cases, the gender non-conformity existed even as they became adults. And you might have an adult who's gender non-conforming, who's actually heterosexual and who's been subjected to violence and harassment as well. So the bottom line is here that you cannot predict adult gender identity or adult sexual orientation from childhood gender non-conformity. However, if you speak to people in the LGBT communities, many of them report being gender non-conforming as children. So you can look at it this way. You have a pool of gender non-conforming children. Some of those children grow up to be LGBT, but not all. But if you look at the LGBT adults, most of them come from this pool of gender non-conforming children, but there are gender non-conforming children who do not belong to that pool. Also, gender non-conformity or gender non-conforming expression is not an identity. And a child as young as 2 or 3 may be gender non-conforming without having any sense of the child's gender sexuality. If there is time, I'm going to play you a video, but I will try to go through the content first. We're nearly at 3:30. But if I can't go through the video, I will share with you a YouTube link you can look at later. Okay. Yeah. Okay. Now I'm going to talk about something that the psychiatric field defines as gender dysphoria. Dysphoria means distress, and gender dysphoria refers to an individual's acute discomfort or distress with an assigned gender. So you may have a female assigned child who absolutely detests having long hair, who refuses to urinate sitting down, who sometimes feels that, that they want to have a beard and facial hair and be like their father. Such children, some of these children, especially those who are also uncomfortable with their body parts, those are the ones who are most likely to want to have surgery as adults to align their body with their gender identity. But we have to remember that not all transgender people actually want to align, and some of them may not be able to afford to align because surgeries are hugely expensive. Some may not be able to align because of other health conditions, and surgery or hormone therapy is not advised for them also. So the important part here is for an individual who actually wants to have hormone therapy or surgery as an adult, they need to go to a psychiatrist and get a diagnosis, if you will, that they have persistent gender dysphoria. Some of this gender dysphoria may manifest very early in age, as early as 2 or 3. But last week, I interacted with an individual who felt gender dysphoric all their life, and after retirement at 60, only mustered the courage to come out and say that I've been dysphoric all my life. The whole world sees me as a man, but I'm actually a woman. So it's possible that people may come out as transgender later in life, but they may feel gender dysphoria quite early. So in terms of terminology, the American Psychiatric Association uses the term gender dysphoria. The World Health Organization uses the term gender incongruence. But until 2022 in India, there was a diagnosis called gender identity disorder, which basically said being transgender is a gender identity disorder. And the WHO removed that classification and removed the word gender identity disorder and replaced it with gender incongruence. Now, the reason we want, or doctors who want to prescribe hormone therapy or do surgery, want a letter from a psychiatrist is that they want to make sure that the individual is facing gender dysphoria and not a psychiatric condition like delusions or schizophrenia. Because in delusional disorder, you may have a man thinking of themselves as Indira Gandhi or Katrina Kaif or whatever. It would be delusional. It would not actually be distress with their assigned gender. So the psychiatrist has to rule that out and say the person has no psychiatric morbidity. The person has gender dysphoria. That's all. So a note about gender dysphoria versus gender non-conformity. So a child who is gender non-conforming may or may not be dysphoric. In fact, I would say about 20 to 30% of them may be gender dysphoric. The others may not be. Okay. Okay, I'm going to take a quick half an hour. It's been half an hour. I'm going to take a quick break to invite questions, comments, reflections before going on further. If all of this is going above your head or you want me to repeat something, please go ahead. Any comments, reflections, or confusions on based on what I've said so far? Some of it may go against what you've been believing so far also.
Doctor, in terms of awareness, there is so little awareness about these classifications.
Yeah.
Most folks, because of whether it's movies or because there's a lot going on in the media, especially after the section was removed by the Supreme Court, and it, they made it. They removed the illegal part of it to homosexuals or lesbians to coexist together. So after that, there is at least some talk going on about it. But in terms of this level of detailing and classification, there is not. I think there's next to zero awareness in the public. Most people think of gays or lesbians or, like you mentioned, transgenders. They confuse them with the kinnars who are at the signal, and they look down upon, thinking they're just doing sex work. And in the common population, I don't think there's this level of awareness at all.
Yeah, you're absolutely right. I would go on to add, even if you leave the common population and you look at the medical subpopulation, a lot of this awareness is not there either. As part of our work, we have analyzed medical textbooks, MBBS and MD textbooks from psychiatry, pediatrics, obstetrics and gynecology, whole bunch of subjects. Yeah. And we found that in many of the textbooks, even though in the year 1990, the World Health Organization issued a statement saying that they were removing homosexuality from the category of mental disorder, the textbook that is printed and reprinted and even now being used by students in India has lists homosexuality as a psychosexual disorder. So there is a lot of ignorance even among healthcare providers. People confuse between gay and transgender. Yeah, there are lots of this thing. So one can't entirely blame the general public when this kind of ignorance is also there in the medical textbooks, but some change is on the way. For example, 2 years ago, there was a court case in the Madras High Court that I happened to be involved with in terms of actually making the judge aware. And one of the things that the judge wrote in his verdict is that the textbooks have to change. So he actually wrote to the National Medical Commission, which has, as of now, modified 2 subjects, forensic medicine and psychiatry, to make them more up to date on LGBTQIA health concerns. But the textbooks have not yet changed. So the teachers who are aware, who have kept up with the science, are changing it in their lectures. But the textbooks, unfortunately, contain the same, pathetic content. Okay, Anita has asked, is it a genetic issue? Could Anita clarify? You could type here, what is a genetic issue? You're talking about sexual orientation or gender identity or what? Please clarify. Okay. Since there's no response, I'm going to try to answer for both. So the question as to whether it is a genetic issue, by which I mean, I think the person means that the person has no, sexuality. Okay, so the question is probably, is the sexuality something that the person has, is innate to that person? Okay. Is the sexuality something that is innate to the person, or is it something that is influenced by the environment, which could be upbringing, it could be media, it could be peer influence, etc., etc. Okay, so the answer to this is, to the best of our knowledge, in the peer-reviewed studies so far, sexual orientation is not caused by external circumstances, as in social environment or media or friends or Bollywood or MTV or whatever. But innate does not always mean genetic. So if you look at it from a medical perspective, there are certain things like epigenetics, there are also developmental pathways. For example, if a fetus is exposed to higher levels of estrogen while developing, while in the uterus, this is known to affect certain aspects of sexuality. So it is not necessarily genetic, but it's still innate in the sense of being something that the individual has no external control over, and the parents also have no control over. There has been one study, one large study that was done in 1990, 1991 from the National Institute of Health in the US, where they they used population genetic approaches, and they looked at hundreds of adult gay men whom they recruited from newspaper ads and online ads. And they found a pattern of that was consistent with X-linked inheritance. So if a man was gay, it was more likely that the men on the mother's side of the family who shared that X chromosome were gay. Okay, so a maternal uncle and a nephew, we found much greater proportion of such pairs than expected by random chance. However, there have been a couple of other studies that tried to expand the study. So one of them was in Canada, one of them was in Europe, and they looked not just at gay men, but they looked at bisexual people, lesbians, etc. And when you increased your population diversity, such an effect was no longer detectable. But it is possible that at least for some people, like the LGBTQIA community is quite a diverse community. Even if you look at lesbian, gay, and bisexual, it's also a diverse community. But what we know for sure from attempts by external people to change sexual orientation, like for a long time, it was, and even now this happens, where parents will take their child to the doctor, pediatrician, or psychiatrist and say, "Doctor, my child is abnormal, cure my child." And in the parents' mind, being gay or being trans is an abnormality. And the doctors will try and do this aversive therapy where they will show the male child, pictures of, naked men, and then inject them with or administer an emetic, something that causes nausea, or give them electric shocks, etc. And then they would show them images of nude women, and then they would be put to listen to pleasant music or something like that. And the idea is just like Pavlov's dog salivating. If they could, use this kind of aversive conditioning to change the sexual orientation, a lot of doctors have made a lot of money on this also. But we know from this that most of this does not work. And also, if you read the scientific papers that have published successes, for many of these doctors, the success is the patient got married. So we all know that everybody gets married, whether homosexual or not, asexual or not, whatever. So the fact that the person chose to get married could simply be that the person succumbed to the combined pressure of the parents and the doctors and said, "Leave me alone, I'll just go get married." But that was flaunted as a big success in the medical journal, including journals of the issues of the Indian Journal of Psychiatry into the 1980s. Now, the National Medical Commission, as of 2 years ago, has said that such attempts, which are called conversion therapy, should not be done. And if an MBBS or MD doctor practices this, they can be labeled as having engaged in professional misconduct, and they can lose their license. But such practices do continue, and the doctors are clever. They will not do it themselves. They'll ask their clinical psychologists to do CBT, cognitive behavior therapy, because there is not a similar ruling that impacts or policy that impacts the clinical psychologists. So let me go back to my slides. I have one more thing to talk about. So to answer your question, is it genetic or not? One thing we know is that for a lot of people, they describe their sexuality as innate, something that they had no control over. And certainly it's not bad parenting or movies or social influence. But whether it is genetic in the specific context of, is it something that is hereditary? There is some evidence for it in gay men, but not if you look at the entire LGB umbrella, ignoring trans and intersex, that even, that effect disappears. So all we can say is that as long as the individual has a sexual orientation that feels natural to them, attempts to change this by external people are both unethical and unscientific and now illegal. So I'm going to conclude this entire section with talking about sex that we think we all understand. When it comes to body parts, you would assume, and correctly so, that females would have these body parts. They'll have a vulva, they'll have a cervix, uterus, fallopian tube, ovaries, etc. The male would have a penis, testicles, prostate, etc. If you go down, drill down to the genetic level, males have an XX sex chromosome combination, and females have XX and males have XY. If you look at it in terms of endocrinology, males have more testosterone than estradiol or other estrogens, and females will have more estrogens than androgens, of which testosterone is an example. And all of this comes from the sex determination system, where the father contributes either an X or a Y chromosome from his sperm, which fuses with the X of the female, because female is XX. And then depending on whether the zygote is an XY or an XX, you'll get a male or a female. But this is very simplistic. And we know that this alignment of chromosomal configurations, hormonal proportions, internal and external body parts is not always the case. In about 1 in 100 cases, you actually have a deviation. For example, you may have an infant that's born with seemingly with a vulva. Doctor says you have a girl. Parents raise the child as a girl and find out that at 12 or 13, whenever the child is supposed to enter puberty, the child is not menstruating, not developing breasts. The parents panic and go to a doctor, and the doctor may order a karyotypic test and find out that the child actually genetically is XY. But as the developing embryo did not respond to the androgens, to the testosterone, and developed into with an external female morphology, even though they may be internal testes. So all of these are called atypical sex characteristics, and people with atypical sex characteristics are referred to as intersex people or people with intersex variations. So in the example I gave, the child looked female based on external or morphology, but the fact that the child was intersex was only known at puberty. But there may be other children for which right at birth, the child is born with genitals that are somewhere intermediate between male and female. So remember, I told you that in that particular example, the female-bodied child was actually genetically male, but the embryo did not develop in full response to testosterone. So that is a condition called complete androgen insensitivity syndrome, CAIS, which is one of the 30+ intersex variations. But all these intermediate anatomies are what are called partial androgen insensitivity syndrome, or PAIS, where the body responds only partially. And how partially or how completely it responds results in the how indeterminate or how ambiguous the genitals are. Now, there are also other intersex conditions. For example, we saw that females have XX and males have XY. There are also embryos that are developing with XXY or just a single X, and these have traditionally been considered sex chromosome syndromes. So, for example, XXY is called Klinefelter's, single X is called Turner's. So these are all other examples of intersex conditions. Intersex conditions have traditionally been referred to as DSD, which stands for disorders in sexual development, and they were thought to be very, very rare. But now modern science and modern advances in pediatrics and genetics and pediatric endocrinology have shown that these intersex variations are actually much more common than thought. And many of them are quite harmless in the sense that the individual suffers no obvious harm other than the social harm of being perceived as, abnormal. So the move, even within the medical field, is to rename DSD to differences in sexual development rather than disorders in sexual development. Now, in North India, what we see is children born with atypical genitalia like this, they are considered to be a curse. So the parents will immediately give away such infants to the Hijra community. This leads to the misconception that Hijras are all intersex individuals. Actually, Hijras are not all intersex individuals. Maybe about 10% of those in the Hijra community are intersex because they were abandoned by their parents. And last week, I was doing a training for the district child protection officers who are part of the Women and Child Development Department in Tamil Nadu. And we learned that in many cases, the child homes have intersex children because parents abandon the children. I heard of a case when I was living in the States of an Indian family who tried to flush their intersex child down the toilet and kill it. We've had people throw them off the highway while driving in their car. So all kinds of horrible things happen. In the medical context, sorry, I should have given a trigger warning for this. In the medical context, what happens is many doctors will not know what to tell the parents. So many doctors actually have historically operated on these intersex infants with ambiguous genitalia. They see the organ, they think it's too small to be a penis, too large to be a clitoris. So they'll chop it off and design a vagina and say you treat your boy, you raise your child as a girl. And this is again considered unethical and unscientific. And in the states of Tamil Nadu, it is banned now. And Delhi is about to bring about a ban. But we are hoping this ban will be in the entire country. The idea is that if the child is born with an intersex condition and it does not appear to be life-threatening, then don't do any surgery. Wait till the child is old enough to arrive at a gender identity and to see whether the child actually wants a surgery or not in the post-adolescence. But otherwise, don't do a surgery. There may be some cases, for example, the child is born with a urethra that there is no urethral opening. So there's no way for urine to pass. In such a case, you might need to do a surgery, but you don't have to refashion or remodel the genitals at all. So to summarize, when we talk about LGBTQIA, my last two slides were particularly about intersex children. And I wanted to say that they are about 1 in 100. Some are visible at birth, some may be visible in adolescence. Sometimes they are not visible or apparent until much later. I have a friend who's a gynecologist in Kolkata, and he had a family bring a woman to his clinic because she was unable to conceive. And then they did all the scans and found out that she was, while she had gone through puberty and phenotypically was female in every sense of an adult, she actually had an intersex variation. And the doctor was scared to tell this because they were afraid the in-laws would, find a way to get rid of the daughter-in-law. So he had to lie and say it's just some problem, and but she's your daughter-in-law and you have to treat her like a member of the family. If you want to adopt, you can adopt a child or something, but she's not able to conceive. So sometimes intersex variation is only found out much later in life also. Okay, now I'm switching from the medical to the social. When we talk about LGBTQIA, as we said, a lot of people, especially when it comes to Hijras, actually, acknowledge that there's mention of Hijra community in Indian culture and Ramayana and Bhagavad Gita and all of that, or Mahabharata, sorry. So, and they say that gay, lesbian, bisexual is what is alien to Indian culture. You don't find things like this in Indian culture. It's all Western influence. But actually, there are plenty of examples from, Indian mythology and temple sculptures, etc., for the entire LGBTQIA spectrum. So you have figures that are half male, half female, which is actually a bilateral form of an intersex variation, which you see depicted in the Ardhanarishwara. In non-colonial communities like this Manipuri community before it, or which is not touched by Hinduism or Christianity, and they follow just the native traditions, they revere trans children as being sacred, and they worship the children, etc. You have examples of everything from oral sex to orgies in temple sculptures. not just Khajuraho and all, but also in the Madurai temple in different parts of India. So I'm not saying that LGBT people were completely accepted in India before colonization happened, but there was certainly acknowledgement that it was there, and it's there in the Kama Sutra, etc. And people tolerated it. They did not jump up and down and have a pride march, but they tolerated it as long as it didn't interfere with people getting married and having children, especially male children. So people who were not entering family life, were outcast, but otherwise they were there. And there was people also found social roles, like some of the folks who are trans were probably incorrectly labeled eunuchs and used to guard the temple, the palace harems and so on and so forth. And if you look at the Manusmriti, homosexuality is only condemned if an upper caste man has sex with a lower caste man, and the condemnation is only for the upper caste man. He has to go and purify himself with the Ganga after doing this. So there's no major this thing. And if a woman has sex with another woman and that other woman is unable to get married because of her reputation being sullied by this, then the older woman will have her head tonsured and have to walk through the town on a donkey. So there are all these kinds of things if you read, Manusmriti and Kama Sutra and Koka Shastra and all of these things. So the other set of arguments against LGBTIQ is that it's not found in nature. But behavioral ecologists, behavioral geneticists, so on, have studied over 450 species of mammals, reptiles, fish, birds, and insects where same-sex behavior is found, where individuals, especially fish and lizards, remain one sex up to one point in their life and then they change sex. In many reptiles, sex determination is temperature dependent. So how deeply the eggs are buried in the soil or in the sand, and whether they are exposed to the elements determine how many of them are going to be male, how many of them are going to be female. So there's all kinds of diversity. We see them among primates, we see them among birds, we see them among cetaceans, among dolphins and so on, penguins, etc. And it's not just historically, many behavioral scientists have said, okay, no, these are just animals being horny during mating season and they don't know who they're having sex with. But we see examples of two female swans actually being together for multiple breeding seasons, stealing eggs from other swans and raising them and being very good parents. In many zoos around the world, it's very common to see same-sex couples of penguins also, two females or two males, raising eggs and hatching them if they're given viable eggs. So we have the medical argument, we have the biological argument, we have the social arguments. Now, why are we looking at LGBTQIA, especially in this context around healthcare? We have to talk a little bit about society as a whole. We live in a patriarchal society like most other societies. Everyone is assumed to be attracted to the other gender, to grow up, have marriage, and bear children. And children who are gender non-conforming face bullying and other abuse. The mental health impact on children and adults can be suicidality. Also, as I spoke about earlier, there's conversion therapy, which is where unethical mental and medical professionals say they will change the sexual orientation or gender identity using medical means. I gave you the example of aversive therapy. I gave you the example of electroshock, etc. Often what they do is that they just load the individual with very high dose antidepressants, which effectively kill your sexual drive. So they're not changing sexual orientation or anything. They're just destroying the sexual desire by loading them full of SSRIs and other antidepressants. So all of these so SOGIESC is a term that the UN system uses, stands for sexual orientation, gender identity and expression, and sex characteristics. So I've actually, when we talk about sexual orientation, when we talk about transgender, cisgender, I'm talking about GI. When I talk about gender non-conforming, I'm talking about gender expression. When I'm talking about cisgender, I'm talking about, talking about intersex, I'm talking about sex characteristics. So we have all the issues in society leading to low self-esteem, depression, anxiety, eating disorders, drug abuse, self-harm, suicidality, and other problems. Okay. There are data from studies, mostly in the global north, that have shown that among gay, lesbian, bisexual adolescents, not transgender in this particular study, higher thoughts of suicide and larger number of attempts at suicide compared to those who are not gay, lesbian, or bisexual. And the figures are much more alarming for trans people. 41% can't change their gender legally. 57% were rejected by families. 19% experienced homelessness. 19% refused medical care. 47% have attempted suicide. Now, this particular figure, it's interesting to know that 52% of lesbian and bisexual adolescent girls, not trans, have actually attempted suicide. So that's a huge number. Whereas this is for trans people across their lifespan, not just adolescents. But this is from the US, this is from North America as a whole. Overall, it portrays a very glum picture. And you can think about, imagine how all of this will translate into availability of healthcare that is sensitive to the needs of the community. There is among the different countries, Australia has a very strong LGBTIQ palliative care project where they've carried out oral histories of a lot of older people and people who are living with terminal illness, people who need palliative care, etc. And these are a couple of quotes. Health professionals often don't understand my identity, and I've had to spend a lot of time educating them. This creates an added burden, and I've avoided care because I don't feel safe, respected, or supported. The current public health system sees everyone as a UR number. Here we can say Aadhaar number, and rarely do staff take the time to ask relevant questions and give appropriate responses. So imagine a cisgender woman, a person who's not transgender, going to a gynecologist for some sexual health issue. The first question the gynecologist in India will ask is, are you married? So that question is supposed to be revealing all the doctor needs to know about her sexual habits, her sexual orientation, etc., etc. So if she's not married, she's in a live-in relationship with a guy, or she's not heterosexual, she's a lesbian, the opportunity for even raising these questions doesn't arise. So many people, if they can avoid declaring their sexuality, will actually not declare it. And this can itself result in misdiagnosis. So one second. Okay. Couple of lines on what the law says. We've already seen that medical science has said that being LGBTIQA is not a disease. It's not a psychosexual disorder, psychosocial disorder. Since September 2018, it is no longer a crime to be in a same-sex relationship. And since 2014, both of these are Supreme Court verdicts. Trans people have protection under the law. And in 2019, there's also a parliamentary act called the Transgender Rights Act. So we've actually, before 2018, had cases of doctors refusing to treat LGBTIQ people for STIs. This was examples we had in Delhi, where the doctor said, if I treat this person and the person becomes well, then they'll continue to have sex. And I will be promoting an illegal activity. So I don't want to see this patient. So these kinds of things have also been observed and documented. Okay, just a line about conversion therapy. One of the strongest advocates for banning conversion therapy is Professor K.S. Jacob, now retired. He was the head of the Department of Psychiatry at Christian Medical College, Vellore. And he was also the editor of the Indian Journal of Psychiatry for many years. And he has written a lot of editorials and tried to influence the psychiatric community not to engage in conversion therapy. The Madras High Court has banned conversion therapy. And after this, in 2022, Kerala High Court also banned conversion therapy. And National Medical Commission, which I mentioned earlier, has classified conversion therapy by allopathic medical professionals as professional misconduct and notified all state medical councils. Okay, so now I'm in the last 2-3 slides before we get into discussion, and the time now is 4 o'clock. I'm going to again take a 5-minute pause and see if there are questions so far in the last half hour. Comments or reflections? Reactions? Anyone who has not had anything to say? Okay, the one thing that someone only understands their gender only after marriage, whether they are gay or lesbian. Mohammed Suhail, what you're saying is partially right. It would not be understanding their gender, it would be understanding their sexuality. But yes, there are some people who become aware of that they are actually not attracted to the other gender only after marriage, because also in our culture, traditionally, sex before marriage has not been encouraged. And people think, after I get married, all will be fine. And then they realized that, it doesn't work. So those are unfortunate situations. There are also situations where the parents know that their son or daughter is gay or lesbian, but still force them into marriage. And we also have heard of some cases where the individual who is gay or lesbian cannot conceive of leading an open life and agrees to the marriage also. So all of these are unfortunate situations and cause a lot of trauma to the other person in the relationship, like the heterosexual woman who's married to a gay man or vice versa. So Mohammed, your point is very important. Only thing is that someone only understands their sexuality after marriage, whether they are gay or lesbian. If they only understood their gender after marriage, then possibly they were transgender rather than cisgender. But yeah, your basic point is taken. But there are many such cases, and hopefully with more and more openness, at least for the sake of avoiding such unfortunate marriages, people are, within the community at least, encouraging people not to, get married until they are very sure of where their attractions and desires and their gender lay. Okay. How would you suggest large-scale public awareness programs, as general public seems to be so away from the nuances? Every time I try to do some research about the community, it is very disheartening. I think the one single successful large-scale public awareness program was Amir Khan's Satyameva Jayate many years ago, as a result of which actually hundreds of people got aware and sensitized, and hundreds of people from the community actually got their parents to watch this and then came out. I see a couple of people, Narmada and Shalaka. Did I pronounce your name right? Okay, could you both say, and then we will ask Indra to say what they wanted. Yeah, Narmada, would you like to go first?
Sure, yeah, thank you. I was going to ask, so it looks like for a very long time, up until very recently, we've pathologized gender and sexual orientation. And anyone who identifies with the LGBTQIA plus community must be deeply traumatized by the healthcare system. How does one go back into the system when they're seeking healthcare? So my understanding is that the rules have changed, the legalities have changed, but we even spoke about this with respect to palliative care in cisgender heterosexual populations. You might have awareness of palliative care, but most private hospitals, for example, do not actually provide it. How does it apply to the LGBTQ community?
Yeah, thanks. I'll get back to you. I want to hear the other questions also, so in case I would like to combine them. Yeah, go ahead, Shalaka, and apologize if I'm massacring your name.
No, it's absolutely pronounced it perfectly. So, doctor, I had a question on how should the medical community and anybody else in the healthcare sector deal with these identity issues, yeah, especially in basic documentation, just addressing them in the right way. How do you get it right? Because healthcare, the clinical aspect of it is so much related to the biological aspect of it. So without being hurtful, without being offensive to the people who need the treatment, what do we do?
Okay, so these two questions are related. One is about training and the other one is about practice. I'll try and combine them. Indira, could you go ahead?
Yeah, I think, hello, my question is also related, and I'm wondering if there have been cases in your experience of an older LGBTQIA having terminal illness. Are they, how do they, I mean, already the medical system is against them in some ways. So how do they cope with this, terminal illness, and there must be cases where you might be aware of. I just wanted to know that.
Sure. So let me try and, are there any other questions or comments, or may I attempt to respond? Okay, so Narmada, like you asked, certainly whether it comes to palliative care or some new area, LGBTIQ is also an area where the traditional medical knowledge has either not dealt with it sufficiently or caused more harm than good. The textbook still saying it's a psychosexual disorder. So we need to do two things: tackle those who are currently students and tackle those who are in practice. So for those who are currently students, changing the curriculum and their teaching, it's easier said than done, but that's what needs to be done. And hopefully the NMC will result in some changes. And for people who are actually practicing, one of the things we have been trying to do is reach out to the professional associations. For example, there is the Indian Psychiatric Society, there is the Federation of Obstetric and Gynecological Societies of India, FOGSI. There's the Indian Academy of Pediatrics, IAP. There's, of course, the IMA. So we have done a lot of CMEs, or continuing medical education sessions, for the people who are members of these associations. And we have also tried to infiltrate both government and private medical colleges and speak about these. And nowadays, actually, more and more medical students are also coming out as queer or trans and engaging in discussions on campus. So, for example, last month, my colleagues and I were doing a training for the obstetrics and gynecology department at UCMS, University College of Medical Sciences in Delhi. And there were quite a few students who were from the campus LGBTIQ group. They came afterwards and spoke to us, and they asked for another event that they had on campus. So I think more and more students and sometimes faculty come out also, the better it is. But yeah, the field is notoriously conservative, and they think that biology is everything, which actually it isn't. I think the in-service training, the teaching of students, and regular sessions, and you can't just go away from a 1.5-hour session like this and expect to be transformed. So it has to be ongoing. And one of the reasons I'm so appreciative of Pallium India for organizing this session batch after batch is that I've actually had people who did this batch like a couple of years ago, who then reached out when there was a particular case and wanted to know what kind of referral can they do, how can they support the person. So in terms of practice also, there are do's and don'ts, and I'll be talking about some of the do's and don'ts in the remaining 15 or 20 minutes. And there are some best practice guidelines both for palliative care and for healthcare in general. So I'm happy to share references as well. Now, do I know people who are who are older or who have been dealing with a terminal illness and not got palliative care? Yeah, I know people from the traditional Hijra community who actually passed from cancer, and they were not that old. They were in their 50s and 60s. And to a certain degree, because there is that kind of community living and setup, what we call the Dhera or the Jamaat system, there's a certain amount of non-medical care, like bringing food and so on, that the peers are able to do. But for people who do not stay in that system and people who don't have the resources to seek out even basic health care, let alone palliative care, it is a sorry story. We know a lot of people are older, they have been living on their own, and suddenly we hear that they died of something or the other. Sometimes it's also not known what they died of. And we also know that people do see a very bleak future or none at all, and also choose to take their life. So yeah, I'm sure that there are a lot of narratives waiting to be excavated, but hopefully we can, through this kind of awareness, at least try and reduce in at least the context that we work in or are able to touch. Definitely there are situations, and we know, for example, there is some epidemiological data that women who don't have children who are nulliparous in medical terminology, are more vulnerable to certain kinds of cancer, like breast cancer, because the body is exposed, protracted exposure to estrogen. So based on this, people have
It's
found,
open.
sorry?
No, sorry, sir.
Yeah, that the lesbian community may be at higher risk of certain cancers. So this really needs to be researched, and it also needs to translate into a lot of preventive medicine before we actually get into the palliative thing. So for many people, it's even traumatizing to go for a pap smear or a mammogram, either because they are transgender and they are embarrassed about their body parts, or they are just afraid of the kinds of questions that they will be asked. So basically, we need to remove the fear and hesitation to seek preventive healthcare, while in parallel working on the curative aspect and the palliative aspect.
Doctor, could you share the, the oral history in Australia with the LGBTQIA
Yes.
people?
Coincidentally, I'm
yeah.
going to share this PowerPoint with everyone, and it actually has the link to the Australian study.
Okay, thank you.
Before I forget, I'm typing my WhatsApp number and my email address. That's Sati with 2 A's and 2 I's, and that should have been +91 for the mobile number. So let me just go back to my slides, and I'm almost close to wrapping up here. Okay, so barriers to accessing palliative care for LGBTIQA communities: estrangement from natal families. Many people have left home, their family did not support them, or they ran away and joined the trans community living. That is one aspect. The other aspect is non-recognition of relationships with those of the same gender. So the parents and immediate natal family will only think of them as married if they have an other gender spouse. The person may actually have a same gender partner who's hidden away and who is not even allowed to make healthcare decisions, or who's not even involved in the care. During COVID, a friend of mine who was in his mid-30s and had been with his boyfriend for nearly 15 years, these were two men, one of them fell very, very seriously ill with COVID and was in critical care. And there were decisions that needed to be made about admitting, about all of that. And they refused to recognize the partner, even though they knew that the person actually opened up and said, "This is my boyfriend." They insisted only your parents can make this decision, and packed him off in an ambulance to the next district, where the parents, who were actually not supportive of this person's sexuality, but they took care of him because the health system did not recognize this. And so this is also an issue. If you're a palliative care provider and you're visiting a client, don't make assumptions that just because they are not married or that they are divorced, that they don't have a partner. They might actually have a partner whom you can involve. History of hostility and indifference in healthcare settings. Already said a lot or ranted a lot about this. And lack of awareness. One can be generous in saying that a lot of the medical education and research has been grounded in a very cis heteronormative paradigm. So you can't even blame the healthcare providers or the palliative care providers because they don't know any better. So that also has to be, it's no excuse any longer. So that actually has to be addressed. So I'm going to go over 2 or 3 slides of best practices and then conclude with the Australia example. So one thing is, if you're a palliative care provider, recognize that the other family members who are around the client needing palliative care may either not know or may not approve of the client's sexual orientation or gender identity, SOGI. So you may actually have to find spaces and windows of time to actually engage with the individual without the natal family present, assuming that that individual is in a position to talk. So you have to utilize respectful and sensitive ways to elicit information. Like you can ask them, your family said that you're not married, but do you have somebody in your life that you would like us to know, to notify about your health condition. And you don't necessarily have to risk by, saying, are you gay? Do you have a same-sex partner? Because maybe some people would actually get upset, offended by that if they are deeply religious and conservative, but you can make it more open-minded. Sometimes people have their special friends who may be of the other gender and they may not be married, or they may even have special friends of the same gender. So whatever it is there somebody who's important in your life? So you can ask questions like that. And do not make assumptions based on appearances or behavior. Just because a man looks stereotypically masculine or a woman looks stereotypically feminine, you can't assume that they are heterosexual and cisgender. And so the article here is from oncological nursing, and I think I have a bibliography also to share with this. So, and also, for example, there are transgender people who have lived with gender dysphoria, and they are very uncomfortable about their bodies. They may have grown up in a time when surgery could not be even imagined. So you may have a trans woman who is in her 60s or 70s, who has never had the opportunity to come out, had never had the opportunity to do have a surgery, and maybe harboring a great deal of embarrassment and shame about her body parts. So in situations like that, just like in general for history taking and for physical examination, you would ask consent. You can ask consent, and you can ask them to indicate by blinking once or twice, are you comfortable with my examining this or examining that, if it's necessary, right? So these are ways in which you can bring about greater comfort, higher healthcare satisfaction rate, and improve the relationships. So this is again from the same recommendations from the same article. Understand the lived experience of LGBTQ patients through their experiences of multiple external and internal stressors, implicit and explicit bias, oppressive and discriminatory encounters, and destructive healthcare systems. Inquire about existing families of choice, relationship partners who are not recognized by law, and explore how they can be included in the provision of care, including advanced care planning. Now, in India, the Mental Health Care Act of 2017, in the context of mental health care, allows an individual to designate someone, this advanced directive, who is not a natal family member or a legally married spouse. So that's actually a very, very progressive move. And people from the community are trying to see if this can be broadened beyond the ambit of mental health care. Okay, 1 second. So the physical examination component of a palliative care encounter, this is from a different journal, Palliative Care and Social Practice, starts with showing respect by obtaining permission to proceed with the examination and allowing the patients to take the lead based on comfort level. Transgender and gender non-conforming individuals, for such people, the identification and labeling of body parts themselves may be extremely sensitive and fraught with dread and anxiety, as this action could be deemed invasive and inappropriate. Openly discuss the purpose of doing the examination. Allow the patients to teach providers about naming their part. What would you like to call this part? And the significance of respectful touch in order to foster trust and build rapport. So obviously in the 1.5 hours, I'm only able to skim the surface, but if you read these articles and go down the rabbit hole of following the hyperlinks, you'll find a great deal of material, including this link, which I found very useful. This is the Australian LGBTIQ plus palliative care project. There are e-learning modules, 4 modules. There are a lot of case histories. So this is actually a fantastic material. Obviously, it's developed in a different culture. So we would have to adapt it for our culture, and that would need to be done. And if there are folks here who are sort of interested in thinking about this more or developing more detailed instructional material, feel free to get in touch. I'd love to work with you all. And yeah, so here are some other readings that are part of the bibliography. There's my email, and I will stop sharing and try to send. Is there a way I can send this in the chat, the PowerPoint?
So you can WhatsApp to me in my
Oh.
number so that I can share it with them.
Okay, okay.
We
And
have a study
because-
group for this batch.
Oh,
We have
okay,
a separate WhatsApp group. I will share. And we
fine,
have an
fine.
LMS
Because
also.
there are a couple of slides that I didn't have before. So it's an updated version compared to the one I used last time. Yeah. Yeah. So, okay. 4:22, we have 8 minutes. Obviously, we can't go into detailed study of discussion of strategies, but maybe at the level of feeling and responses and reactions, maybe some of you have come from a cultural background or a social background where LGBTIQ plus identities and people are considered either sinful or, not to be encouraged, or, other biases that you may have that are understandable given your family or cultural background. I respect that. All I ask is, as a healthcare provider, we have to ensure that the patient's needs come first, and then the quality, we have to do whatever we can to make sure the patient has as good a quality of life as possible. So as long as the patient is not engaging in anything that is non-consensual, it probably helps to be morally neutral about these things. Yeah. So yeah, thoughts, reflections, comments, things you can do moving forward in your respective contexts. Please, I don't want silence. Anything you want to reflect on? Yeah.
Doctor, you mentioned about a video you want to show us. Are you going to share that with Shripriya as well?
Yeah, I will.
Or share the link with us, with Shripriya, so she can share it in our group
Yeah, yeah,
later.
I'll do that.
I just wanted to say,
Okay, sorry.
Most important part.
Sorry. Yeah, I'll just
Okay.
share a link with Shripriya. That's okay. Yeah. Yeah, because going through it, I'll just give you a couple of keywords. So you can search YouTube by not Ryland, sorry, Ryland transgender. And this is like a 9-year-old YouTube video made by the parents of a child who was assigned female at birth, but who is acutely gender dysphoric, and the parents support the child and allow the child to transition early. So this is a controversial topic, especially in even in the Indian context, where if you're following the current discussions in the US and in the UK, there's a lot of discussion on the right age for a trans child to undergo surgery. There is the very difficult CAS review. I mean, difficult in the sense that a lot of what's in there has actually been critiqued. What the CAS review says. But in India, what we know is that no person will offer surgery until the child is an adult, 18 and above. The only thing that may happen if the child is acutely dysphoric is the endocrinologist may prescribe what are called puberty blockers, which basically slow down the puberty until the child is sure of their gender identity, and this is a completely reversible process. But more than that, nothing happens in the Indian context to juveniles, to minors. Yeah. Okay. Mary says, despite all the new laws, still society has not accepted them fully. Hence, care is not readily available for them. As a palliative care, how to handle such a situation? Yeah. Thanks for the question, Mary, and I'd love to hear answers from your colleagues and you. All I would say is, when you go to see an individual, try to let go of your assumptions that the person is heterosexual or that the person is cisgender. If you have an opportunity to ask questions in private, try to do so and try to elicit information. And if there is a way, for example, if you know that the family members are very homophobic, and you can't actually tell them that this man has a boyfriend, you could just use language like has a close friend with whom he has spent many years. So it would be good if that person were also allowed to be part of the spectrum of care. Also, as a healthcare professional, you have to advocate for your patients if the family is aversive to the patient. Yeah, absolutely true. Absolutely true. Yeah. Reflections, any suggestions, what can be done moving forward in palliative care practice or your other kinds of practice? Yeah. Okay. Thanks, Indra, for this. That's awesome. Yeah.
Just to share with others, since I'm an oral historian by training, I just said if anything like this you want to develop, I'm quite happy to come on board.
Okay, okay. Yeah, I think even just if we can have a corpus, a body of case studies of people who are LGBTQIA and elderly. There have been oral studies, I'm sorry, oral histories collected and published recently, but they are just of people who are 50 and above, and not in the, palliative care or, terminal illness type of context. And obviously there are ethical issues and sensitivities to keep in mind. But yeah, I think something like that would be really valuable. Yeah, Shalaka, you have your hand up. Yeah.
Yeah, I just wanted to share something from what I have experienced. So I run a patient organization mostly with terminally ill patients. And 2 years ago, there was this 19-year-old who applied to be part of the organization, who joined a support group. And, in my earlier conversations, he presented himself as a biological male. And over the course of the next few days, we don't immediately add anyone in the patient group. We always have an initial conversation with them. In the next few days, he told me then that, he is suffering from gender dysphoria and I should treat him as a woman. And I said, yes. And then we were discussing her diagnosis and it wasn't good at all. She's a 19-year-old from Delhi, from a middle-class family, parents supportive of all things, but did not know about this. They knew about the diagnosis, but they did not know about the transgenderism. And eventually this young woman told us that, I cannot even deal with this diagnosis right now because my main focus is my transgender identity. I want to be a trans woman. I want to be a woman. And I refuse to do anything about it until this issue is resolved. And my mental health is so bad right now that I cannot deal with a terminal diagnosis. I may die in 2 years, and maybe that is a good thing because I can't deal with this. So I just wanted to share that anecdote.
Okay. Thanks. Yeah, this is very insightful. There was something I was going to say. Yeah, so there's one of my collaborators, in fact, with whom I used to do this palliative care course 3-4 years ago, is herself a critical care specialist doctor and a trans woman. And she has now moved to the UK and she's working with the NHS. Her name is Dr. Samira Jahagirdar. So this next week, she's going to be actually doing a face-off with Cass of the Cass report, sharing experiences from the Indian context in her own journey of growing up. She identified as a trans person only into her 30s and went about it very patiently, got both her parents on board and so on and so forth. So yeah, so she has been doing, initiating a lot of conversations on palliative care, both in the UK among the South Asian immigrant population, as well as when she was here in India. She used to teach in Pondicherry. So I think this is something we should really get into a conversation about, maybe a WhatsApp group or something for those who are interested. And yeah, and thanks for sharing your the case. How I was just curious how the other people in the group responded to her.
She refused to join the group. She said, I don't want anything to do with this right now. I want to figure out my transgender issues first. And she hadn't disclosed it to her own parents or family members. None of her other friends knew about it, maybe probably just one more person. And from my organization also, it was just me who understood, who was told about it. And, I respected her, her choice about this. Yeah. But once in a while, I'm in touch with her. Once in a while, I just say, hi, how are you doing? I hope you're taking medications. Just
Oh, one thing I forgot, I must close with that, is that legally a person in India can identify as transgender even if they've not had hormones or surgery. So they can legally get a trans ID card saying that they are transgender. But if they want to identify, if they are a trans woman and who wants to identify as a woman, they would additionally need a letter of gender dysphoria, etc. The second aspect about surgeries is not everybody can or choose to have all the relevant medical procedures. For example, a trans man may choose to get a chest reconstruction with a double mastectomy, may choose to get a hysterectomy, but there are a lot of people who have a uterus and just have done top surgery. So in the context of healthcare, people have, rather than the usual male-female checklist, they have actually come up with a checklist of body parts, because some people may have some body parts and not have other body parts. They may have a penis and they may also have breasts, or they may not have breasts, but they may have a uterus, so on and so forth. Or they may have a vagina and they may have a prostate. So both for intersex people and for transgender people who may be anywhere on the post-operative to fully operative spectrum, a checklist is a useful thing to have while doing assessments, because I heard somebody mention that it's the biological thing that is important. Yes, the biology is important, but the body parts, again, are not always predictable, are not always concordant with that person's gender identity. So there are things like the body checklist that I could probably also share if someone's interested. So I think I have exceeded the 4:30, the bell didn't go off, but yes, thank you for the opportunity. If Shripriya wants to close, please go ahead. It's been really good having this conversation. Thank you again for being attentive and raising such wonderful questions.
Thank you, Dr. Ramakrishnan. I know that you have a flight to catch very soon and you might be rushing to airport, but still you found out time to join us today and throw light on such a very sensitive topic. Thank you so much for that. And thank you everyone for making the session interactive, because unless and until people like us start talking about topics like this, things are not going to change for anyone. So thank you everyone for joining in, and I could see collaborations starting in the chat itself, like Aparna and Indra were like collaborating between themselves. So I truly hope that things do move forward with this. So thank you once again, sir.
Yeah.
Yes, sir.
Yeah, I missed one question that Anita asked about insurance. Just to say that under Ayushman Bharat, transgender people can now get their surgeries. As of a policy order last year, they can get their surgery covered by insurance. So now people are applying, but as of now, it's not yet translated into reality. In a couple of states, Chhattisgarh and Tamil Nadu, the surgeries are free. And in the state of Kerala, the surgery can be reimbursed, whether it's done in the, even if it's done in the private sector. But apart from that, insurance for everybody is not a reality. Yeah. Thank you.
Thank you so much, sir. Thank you so much. And thank you, everyone. I hope that all these bits of information really will help every one of us in making the lives of some people better. So thank you. And with the promise that we'll be meeting again in the next session with another important topic and yet another eminent speaker. This is Shripriya, along with Dr. L. Ramakrishnan, signing off from the Tips Eco Hub. See you in the next session, everyone. Till then, take care. Keep spreading happiness. Bye-bye.